So we are continuing with our hearing assessment Pure-tone audiometry lecture part 2. And the previous lecture we talked about how to plot on an audiogram, how to determine the pure-tone average, which is the average of the air conduction thresholds for 500 Hertz, 1000 Hertz, and 2000 Hertz. And we do that independently for the right ear and the left ear. And that helps us determine the type of, the degree of hearing loss based on the ASHA's classification. We also talked about how, um, based on the audiogram findings with air conduction thresholds and bone conduction thresholds, we'd be able to determine the type of hearing loss. So we have three different types of hearing loss: the conductive hearing loss, sensorineural hearing loss, and mixed hearing loss. So while the air conduction thresholds lets us determine the kind of quantify the amount of communication difficulties that a hearing loss will have based on the degree of hearing loss, it would not help us determine the type of loss. So we need the bone conduction thresholds to do so. But once we have the bone conduction thresholds, we'll be able to determine the type of hearing loss. So again, to recap, the conductive hearing loss is when the problem is in the external ear and or the middle ear. So if we do have a conductive, if you have a problem in the middle ear or the external ear, its sounds need to be louder for the person to hear. So the air conduction thresholds for this person is going to be more than 15 decibels, the limits that we consider for hearing with the normal limits. So that'll be yes. And based upon how much the pure-tone average is, we'll be able to determine the degree of loss. But then we need to find the bone conduction thresholds for both the ears. And for a conductive hearing loss, since the problem is in the conductive system, and if you can bypass that, things are within normal limits in the cochlea and the auditory nerve, the bone conduction thresholds are going to be within normal limits. So for this question, if the bone conduction thresholds are more than 15 decibels, the answer would be no. And if you were to compare the air conduction thresholds and bone conduction thresholds, you're going to have what we call as a significant airborne gap. In other words, the airborne gap is going to be more than 10 decibels. And for purposes of this course, let's just compare the air conduction thresholds and bone conduction thresholds for those three frequencies that we used to calculate the pure-tone average, namely 500 Hertz, 1000 Hertz, and 2000 Hertz. In other words, if the bone conduction thresholds are within normal limits for 500, 1000, and 2000 Hertz, and you see a significant airborne gap, then your diagnosis would be that it's a conductive hearing loss. For sensorineural hearing loss, again, the problem is in the cochlea or auditory nerve. The sensory part of this diagnosis refers to the cochlea, and the neural refers to the problem in the auditory nerve. If there's a problem in the cochlea or auditory nerve, the pure-tone audiogram is going to look similar, and that's why it's clubbed together. We need to do other special tests to kind of do a differential diagnosis for the problem is in the cochlea or in the auditory nerve. But based on pure-tone audiometry, either way, the problem is going to show up as a sensorineural hearing loss. Again, the air conduction thresholds are going to be naturally affected. So this person's got a hearing loss, so that would be yes. But for a sensorineural hearing loss, the bone conduction thresholds are also affected. In other words, the bone conduction thresholds are going to be more than 15 decibels, telling us that even if you were to bypass the external ear, the middle ear, things don't return back to normal. There is still a loss of intensity of the sound, so this person's got a hearing loss. And if you were to compare the air conduction thresholds and the bone conduction thresholds, they're going to look close to each other. In other words, there's not going to be a significant airborne gap. So is there a significant airborne gap? The answer for that for sensorineural hearing loss would be no. Okay. In a mixed hearing loss, it's a combination of both. So there's a problem somewhere in the conductive system, along with a problem in the cochlea or auditory nerve. So this could be an example of an elderly individual having presbycusis, in other words, a hearing loss because of age, which typically is because of a problem in the cochlea or in the auditory nerve. And transiently or temporarily is also suffering with an ear infection. So there's some problem in the middle ear. So if you were to do a pure tone audiogram on this person, it's going to show as a mixed hearing loss because his air conduction thresholds are going to be more than 15 dB. But if you were to test his bone conduction, they are also abnormal. They are also more than 15 dB. But if you were to compare them, air conduction thresholds and bone conduction thresholds, there is a significant difference between them. In other words, he hears better through bone conduction, but not with the normal limits. So you have a significant air-bone gap. So this would be a mixed hearing loss. So in a mixed hearing loss, air conduction is affected, bone conduction is also affected, but the difference between a mixed and a sensorineural hearing loss is that in a mixed hearing loss, there is a significant air-bone gap, telling us that the bone conduction is not equally bad than as the air conduction. So things improve slightly, but not with the normal limits. So not necessarily you will see the same type of hearing loss in both ears. In the previous scenario, we talked about an elderly individual having an ear infection. It could be that his ear infection is only in one ear. So this person might have a sensorineural hearing loss in one ear while having a mixed hearing loss in the other ear. Another scenario would be that this person has got, well, is an avid hunter and is a right-handed hunter with a rifle. So you could see that this person has got a hearing loss in his left ear, and that hearing loss could be sensorineural in nature because it's a noise-induced hearing loss. But another ear might have a conductive hearing loss. So you might see different profiles, both in terms of degree of loss and in the type of loss in a single person in between the ears. So once we have the pure tone audiogram plotted, um, we kind of get an overall picture of his hearing. And not necessarily everybody's hearing loss would be flat. And actually, most cases you have a sloping hearing loss. And depending upon where the slope is, in other words, where the hearing loss is more, whether in the low frequencies or in the higher frequencies, you might have a high frequency sloping hearing loss or a low frequency sloping hearing loss. Or if it's equally affected at all the frequencies, you might have a flat hearing loss. So here's an example of a high frequency sloping hearing loss for the right ear. So you can see that things are with the normal limits, but progressively there's a hearing loss for the higher frequencies. In fact, this is a type of hearing loss that we would expect to see most commonly seen uh, in cases of noise-induced hearing loss. So they have this typical pattern where there is a dip in the hearing at 4 kilohertz, around 4 kilohertz, and it's sensorineural in nature. I know that because when I look at the air conduction thresholds, which are the circles, and the bone conduction thresholds, which are those brackets, you can see that they're pretty close to each other in this graph. And so there's no significant air-bone gap, and the bone conduction thresholds are affected. So this would be a case of a moderate hearing loss that's sensorineural in nature. And it's a moderate sensorineural high frequency sloping hearing loss to be specific. The adjacent audiogram, you're seeing a hearing loss in both ears, but the hearing loss is more so for the lower frequencies. Um, so this would be a case of low frequency sloping hearing loss. Other kind of configurations you would have is a bilateral hearing loss or a unilateral hearing loss. A bilateral hearing loss is when both ears are affected. A unilateral hearing loss is if the hearing levels are within normal limits in one ear, and then there's a hearing loss on the other side. In a bilateral hearing loss, you might have a symmetrical hearing loss or an asymmetrical hearing loss. Symmetrical is if the degree and the configuration of the hearing loss is similar in both ears. An asymmetrical hearing loss would be if there's the difference in each ear. So here is an audiogram that's bilateral and symmetrical. So the hearing levels are equivalent in both ears. And adjacent to that is a bilateral hearing loss that's asymmetrical. In this case, the right ear is a poorer ear, and the left ear would be the better ear. Um, so just a point that if we were to find such readings, find such thresholds for air conduction in this patient, you would do the bone conduction, or you would begin the bone conduction on the better ear, so your bone vibrator would be placed on the left mastoid in this case. The third audiogram over here is an audiogram with a unilateral hearing loss. The hearing loss is, the hearing levels are within normal limits for the right ear, but for the left ear, this person has got a severe to a profound hearing loss. Severe because the thresholds are 70 dB, sloping to around 100 dB. That would be a profound degree of hearing loss. And you might see such hearing loss in those cases with the sudden hearing loss. These patients, there are some patients that probably just wake up in the morning and find out that the ears are blocked on one side. And if they were to compare the hearing in both ears, they'd notice that they almost can't hear anything in the poorer ear. And if you were to do an audiogram as early as you can, you'd find out that he's got a profound hearing loss on one side. These hearing losses often are idiopathic. In other words, it's hard to pinpoint a cause. Sometimes it might be associated with a facial nerve palsy on the same side. But in many cases, there's no acute cause. Some feel it could be because of just a passing virus that specifically targets a hearing nerve. But the important thing is, if you do hear a person complaining that this is to get him to an audiologist and get him to an ENT as early as you can. Because there are cases where if you see a sudden hearing loss, and if it's immediately treated with some anti-inflammatory drugs and antibiotics, some, if not all, the hearing can be restored. But the longer it takes, typically say if it's more than 3 days, then the hearing loss might be permanent. And these unilateral hearing losses are in a way difficult to remediate because they do pretty well in typical environments because we've got hearing with the normal limits on one side, but obviously they'll have problems in kind of finding out the direction of a sound source. They'll have problems in directing their attention to a speaker because of this hearing loss, significant hearing loss in one ear. When we get to our lecture, when we talk about hearing aids, we would talk about these cross hearing aids, special type of hearing aids that actually might help these individuals with a severe unilateral hearing loss. Other descriptors of hearing loss could be that it's a fluctuating or a stable hearing loss. Some type of hearing loss might fluctuate over time. Common examples of that would be young children with chronic ear infection. So whenever they're having an ear infection that might be triggered by allergies or might be seasonal, they would of course have a hearing loss, but if it's resolved spontaneously or by medication, things might return back to normal. There are also other kinds of hearing loss that actually might be sensorineural in nature and it's fluctuating. A classical example of that would be the hearing loss that we see with Meniere's disease. Oh, excuse me. Meniere's disease. This is a condition where it's associated with acute extreme attacks of dizziness, vertigo, nausea. And if you were to test that person, you'd also find out he's got a hearing loss, but that's fluctuating in nature because these individuals might get episodes of this dizziness and hearing loss, and it might be associated with tinnitus also. And then between the episodes, the hearing might be restored to even normal or a lesser degree of hearing loss. And typically, you see that with young to middle-aged adults. Now, of course, the other type of hearing loss would be that it remains stable. Um, the hearing loss, the type and the degree of hearing loss remains stable for a prolonged period of time. Then you have sudden hearing loss, and we just talked about a sudden hearing loss that's unilateral. Um, Other cases of sudden hearing loss could be a fast-growing tumor, uh, or it could be head trauma. Head trauma, if there's a head trauma that actually might result in a conductive hearing loss because the ossicles are being displaced and a tympanic membrane perforation. Head trauma also can result in a sensory neural hearing loss, like in cases of TBI, traumatic brain injury. Progressive hearing loss is the type of hearing loss that the degree of hearing loss increases um, as time passes. So you example of that would be like presbycusis, hearing loss that you see with elderly individuals. You would expect that the hearing loss increases over time. And what's important is that if you suspect a progressive hearing loss, then you recommend frequent follow-ups to monitor this degree of hearing loss. And if you have fit them with a hearing aid, then you want to make sure that the hearing aid gives appropriate amplification. Other types of hearing loss could be temporary or permanent. Temporary, again, we just talked about in case of ear infection. Permanent is when the hearing loss is not, when you cannot recover or improve the degree of hearing loss. Okay, an important concept when we're talking about pure tone audiometry is cross hearing. If you were to present a sound to one ear, and if you make it loud enough, actually the other ear is going to hear that sound, and it hears it through bone conduction. Um, so if you were to place like supraoral headphones, and if you were to make it loud, so if it was a normal hearing person, if you were to make it louder than let's say 40 decibels, um, a part of that energy is going to cross over as through bone conduction to the other side. And if the other side is hearing is within normal limits, it's going to hear that and the patient might respond. So cross hearing refers to the transfer of energy from one side to another. Um, and cross hearing can be problematic when you test doing pure tone audiometry because one of the goals of your pure tone audiometry is to get ear-specific results. And if you if one of the ear is helping out the other ear, then you would not be able to get ear-specific results. Um, However, when sound travels from one side to another, some of this energy is lost. So it's not like if you give 40 dB through headphones and in the right ear, the whole of the 40 dB goes to the other side. There is going to be some attenuation, a reduction of the amplitude by the time it reaches the left ear in this case. And this loss of energy is what we call as interaural attenuation. And that's the opposite of crossover, because interaural attenuation means interaural between ears, attenuation reduction. And intraoral attenuation is desirable in terms of for diagnostic Puton audiometry, because if there's intraoral attenuation is high, it means that lesser energy is crossing over from one side to another, and more likely you're getting ear-specific results. So this intraoral attenuation, or IA, changes by frequency, by the mode of conduction, uh, and on the person that you're testing. So here's an illustration of intraoral attenuation. So let's say that the ear that we want to test, this case is your right ear. That's the right ear, and that would be a test ear. The other ear would be the non-test ear. So the left ear in this case would be a non-test ear. Intraoral attenuation refers to the loss of energy when sound travels from one side to another. So let's say if you're using headphones or supraoral headphones to test air conduction, um, the intraoral attenuation for headphones is around 40 dB. 40 dB. In other words, there is a loss of 40 dB when sound presented to one side goes to the other side. As I said, um, crossover happens through bone conduction, so the sound that travels from one side to another actually directly reaches the cochlea. Okay, so if you're using supraoral headphones, the intraoral attenuation, as I said, IA is 40 dB. So if you were actually giving, if you were giving, let's say 50 dB sound, 50 dB HL sound, um, 40 dB is going to be lost by the time it reaches the other side. So in this case, only 10 dB is going to reach the other side. So intraoral attenuation refers to the loss of energy when one sound travels from one side to another. Um, so in this case, only 10 dB reaches the other side. But let's say this person has got a unilateral hearing loss. He's got hearing within normal limits in the non-test ear, but let's say he's got a severe loss in the test ear. So in other words, because of his hearing loss, he's not going to be able to hear sounds um, less than 70 dB. However, if you are testing with air conduction using headphones, because of the intraoral attenuation, as soon as the intensity of the sound that you're giving through headphones is 50 dB, part of that sound is going to go to the other side, and if the hearing is better in the other side, this non-test ear is going to help out in this person's hearing, and this person is going to say that I heard the tone. So what that will result is an underestimation of this person's hearing loss in the test ear. Okay, so that's just giving you an example of the consequence of this crossover. Okay, uh, so that's for air conduction. In bone conduction, when you're using a bone vibrator, when you're doing BC testing with a bone vibrator, the intraoral attenuation is close to 0 dB. In other words, how much ever sound you're giving in one side travels over to the other side. Uh, so there is no energy lost when sound travels from one side to another when you're doing bone conduction. And that's problematic, and I think I referred to that in an earlier lecture, that the only way to get ear-specific bone conduction thresholds is to do this procedure known as masking, where we engage the non-test ear with some other stimulus. And we'll talk about that briefly in a short while. So this is another illustration of how intraoral attenuation works. uh, when you're doing air conduction, um, some of the energy is going to be lost, and how much energy is lost depends upon what transducer you use, whether it's a headphone or an insert earphone. But when you're doing bone conduction, almost the same, all the energy travels over uh, to the other side. And the only way we can get ear-specific results when we're doing bone conduction is through this procedure known as masking. Okay, essentially what we do in masking is when you're testing, let's say, uh, the left ear in this case, so if this is the test ear for BC, and this is the non-test ear, the other ear, the non-test ear, the only way to get ear-specific results for bone conduction is to engage this non-test ear with some other stimulus. So you might put a headphone or an insert earphone and give some stimulus like a noise, a narrowband noise if it was pure tones, and engage this ear while you're testing the bone conduction. And that's what we call as masking. So intraoral attenuation and cross hearing depends on uh, some factors. One would be the frequency. Just like as we talked about in acoustics, that lower frequencies can travel longer distances because they can go around objects, such is a case for uh, sounds that you test through um, for pure tone audiometry also. So the lower frequencies have uh, better chances of crossing over. So the intraoral attenuation, the loss of energy when it travels from one side to another, is lower. Higher frequencies, on the other hand, have high intraoral attenuation. So in other words, more energy is lost when a higher frequency travels from one side to another. Okay. So this is an example of uh, intraoral attenuation with headphones on. And so the type of transducer you use also affects the intraoral attenuation. So if you're using supraoral headphones, the intraoral attenuation is close to 40 decibels. So in this case, when you're using a supraoral headphone, and if you were to give a sound as loud as 80 decibels, 80 dBHL, uh, you're going to lose about 40 dB because of intraoral attenuation, but 40 dB of that sound is going to reach the other side. Okay. When you're using insert earphones, the intraoral attenuation is better. In other words, it's higher, and it's about 70 dB. 70 dB. In other words, 70 dB is lost when it travels from one side to another. So in this case, if you were to use insert earphones and present the same 80 dB sound, about 70 dB is going to be lost when it travels from one side to another, and only 10 dB is going to reach here. Yeah. And that's another reason why insert earphones are desirable for testing. Not only they're hygienic, they have a high intraoral attenuation, um, and so it's more likely you'll get your specific results. When you're using a bone vibrator, the intraoral attenuation is 0 dB. In other words, almost all the energy you give in one side, it travels over to the other side. So in this case, if you're using 30 dB, if you're giving 30 dB through a bone vibrator, almost the whole 30 dB transfers to the other side. Um, and that's why I say that when you're doing bone conduction testing, the better cochlear response, no matter where you place it, because the sound travels almost equally in both sides. Um, so again, why does cross hearing affect us? When you're having cross hearing, you would be concerned about getting ear-specific results. In other words, a non-test ear might help out the test ear, and that might end up underestimating the hearing loss. So in other words, if I want thresholds for the right ear, I want to make sure that the left ear is not helping out. And the way we do that is by masking. So we'll talk a few aspects of this masking briefly. So the main purpose of masking is to make sure that one ear is busy while you're testing the test ear. In other words, you're trying to remove the involvement of the non-test ear from the procedure. So again, the non-test ear is the ear that you do not want to help out. It's typically the non-test ear is the better ear, um, and it's a ear that receives the masking signal. Uh, the test ear is the one that you want to get thresholds on, and it's typically the poorer ear. Uh, and of course, we have different symbols when you're doing masking, and most audiograms will give you in its legend what symbols do we use when we plotting masked thresholds. So when do you mask? Whenever you suspect that the signal is being that you're giving to the test ear is likely to cross over to the non-test ear. Uh, there's a number of ways to determine that. One thing you might even ask the patient, where is hearing the tone? So even though you're presenting the tone through your audiometer to the right ear, the patient might report that he's actually hearing it in the left ear. So now you would suspect that the sound signal is crossing over. Another way of determining the need for masking is based on the interaural attenuation. So if you're using a headphone, you know that the interaural attenuation is 40 dB. So whenever you're presenting more than 40 dB, you need to be aware that part of the signal might actually cross over to the other side and might be heard in the better ear's cochlea. So when do I mask for air conduction? Uh, so you mask for air conduction whenever your presentation level exceeds the bone conduction threshold plus the interaural attenuation um, of the better ear. So bone conduction thresholds of the non-test ear or the better ear plus the smallest expected interaural attenuation. For bone conduction, it's almost always, if you want to get ear-specific results, you would have to do masking. Um, so whenever there's an airborne gap greater than 10 dB, then you want to we'll have to do masking to get the mass thresholds for the poorer ear. So there's different kinds of signals you might use for masking. Um, you might use a broadband signal or a narrowband noise or a white noise. Um, and your choice of using one of these signals would be based on the least amount of energy um, and depends upon what testing you're doing. So if you're doing for pure tones, you might choose narrowband noise to engage the non-test ear. Um, if you're doing speech testing, if you want to get masked speech thresholds, then you might prefer using speech noise in the non-test ear to engage that ear. So that's all we're going to talk about masking. Again, it's remember that if you're given thresholds and if it says those are masked thresholds, use the appropriate symbol in your audiogram. So here's an audiogram for a patient with hearing with the normal limits. So you can see that all his thresholds are at 15 dB or better for both the right ear and the left ear. And typically, if you get thresholds that are within normal limits, one would not have to do bone conduction testing. It's when you're seeing a hearing loss, then you want to determine the type of hearing loss, and for that you would need to determine the bone conduction thresholds. Okay, here are some audio pure tone thresholds that I want you guys to practice plotting on an audiogram and determining the pure tone average and making a diagnosis. Um, you might have for an upcoming quiz or for the final exam plot and diagnose audiograms. So I wanted to give you this opportunity for you guys to do this with these practice audiograms. Just a few points. These are four different audiograms actually. So for example, the first audiogram, these are the thresholds you got for the right ear, air conduction and bone conduction. And these are the thresholds you got for the left ear, air conduction and bone conduction. So use this to plot an audiogram. And so we have three more types of hearing loss, three more patients and thresholds. I'm going to be posting a blank audiogram on D2L, so I suggest you guys practice using that blank audiogram. And I'll also create a discussion thread on the discussion board so we can compare your diagnosis for each of those audiograms. So that's 1, 2, 3, 4. I've got a plotted audiogram over here. Again, do the same. Find the pure tone average for the right ear, for the left ear, and determine the degree of loss and the type of loss. And we can talk about this in our discussion board.